Greetings, dear learners. In the last class, we started with the management of poisonings. Under that, we learned the steps of the management of poisoning. In that, starting with the general management of the poisoning, the broad guidelines were the immediate resistive measures, then the removal of unabsorbed poisons from the body, removal of absorbed poisons from the body, administration of antidote, then symptomatic treatment according to toxidromes, further adequate follow-up of the patient, and the nursing and psychiatric care of the patient. Dealing with one by one, we started with the immediate resistive measures. Under that, we learned that first we must remove the patient from the poisonous environment. Then we have to manage the ABCD of the resuscitation. That is the A for airway, then breathing, circulation, D for depression of the CNS, and the evaluation of the patient. Under the immediate resistive measures, we learned in detail the airway and the management of breathings. Under the airway, we learned that we must assess for the oxygen saturation, and if the oxygen saturation is not improving, then we must open up and clean the airway. Still, if oxygen saturation is not getting regular, then we must plan for the endotracheal intubation, and in case still the blockage is there, then the tracheostomy shall be planned. Further, in the management of the breathing, we must analyze arterial blood gas analysis for the acid-base balance, then the tidal volume and the minute volume using a spirometer. If there is any these are inadequate, in those cases, we must begin with the supplemental oxygen therapy using AMBU bag. If after the supplemental oxygen therapy, the patient is not improving, then we may use oxygen mask starting with 28% and then progress to 35%. And if still the patient's condition deteriorates, then we must plan for the mechanical ventilation. Then we started to discuss circulation. Under that, we learned the clinical presentation in case of abnormal circulation. That can be hypotension, hypertension, tachycardia, bradycardia, arrhythmias, and heart blocks. To assess the circulation, we have to monitor blood pressure, heart rate, radial, femoral, and carotid pulses, and echocardiograph. That should be placed throughout the casualty or ICU monitoring system. We also saw the ICU monitor where all these things are presented on the monitor so that we can read them easily and plan the management accordingly. So, coming to the management of the circulation. So, the management of circulation starts with the management of the acid-base imbalance. So, we must correct the acid-base imbalance first, and then we must elevate the foot end of the bed. That is called we must keep the patient in the Trendelenburg position. That will cause increased circulation and vascular supply to the tissues. Then insert a large bore peripheral IV line that should be minimum of 16 gauge, and administer a fluid challenge of 200 ml of saline at the rate of 10 ml per kg in children's. Observe for the improvement in the blood pressure for 10 minutes. Repeat the foot bolus if BP fails to normalize, and assess for signs of the fluid overload. Short-term low-dose vasopressors such as dopamine and norepinephrine may be given if after the fluid bolus there is no improvement in the blood pressure. Hemodynamic monitoring should be considered if those adults who are not responding to the 2 liters of infusion and the short-term low-dose vasopressor agents like dopamine and norepinephrine. The monitoring of the hemodynamic system is done by the central venous pressure monitoring or hourly urinary output monitoring. Patients with the severe hypotension may need more sophisticated hemodynamic monitoring, that can be done by the pulmonary artery catheter and the intra-arterial pressure monitoring. That can also be observed if depending upon the different types of the systems, monitors may be attached and the intra-arterial catheters may be passed that will give the monitoring of the intra-arterial blood pressure and the pulmonary artery blood pressures. That may be done. Then, what should be the low dose short-term vasopressor dose like dopamine and the norepinephrine? Dopamine shall be given 200 milligram, that is 1 ampule in 200 ml of 250 ml of 5% dextrose in a water to make a solution of 800 microgram per ml. Begin with the 1 to 8 microgram per kg per minute, maximum being 15 to 30 microgram per kg per minute, and titrate the dose to maintain systolic blood pressure between 90 and 100 mmHg. Monitor the blood pressure every 15 minutes. Norepinephrine shall be given in the 2 ampules 8 mg to 500 ml of 5% dextrose solution to make a concentration of 16 microgram per ml. Start with 0.5 to 1 ml per minute and titrate according to the clinical response. Monitor the blood pressure every 5 to 10 minutes. So we started with giving the IV line, then we started giving the fluids. If on the fluid it is not improving, then we have to start the vasopressors like the dopamine and norepinephrine. Even though the patient is not improving, then we must switch to the hemodynamic monitoring, and then we must go for the different dosing of the vasopressors. So in order to further manage the circulation, we must look for the other parameters. We should look at the ECG changes and their abnormalities. So obtain an ECG in hypotensive patients and note rate, rhythm, arrhythmias and conduction delays. Obtain an ECG, ensure continuous cardiac monitoring and administer oxygen. Evaluate for the hypoxia, acidosis, electrolyte disturbance, especially hypokalemia, hypocalcemia and hypomagnesemia. They will be giving the changes on the ECG as well. So we must have to correct those electrolyte imbalance, and we must keep those electrolytes or higher, then we must decrease the amount, or if the lesser, then we must supply the electrolytes. So the different types of the waves may be presented on the ECG that we must look and we must manage them accordingly. Abnormal P wave, that is the clinical abnormalities of P wave, occur with genobiotics that depress the automaticity of the sinus node, causing sinus arrest and nodal ventricular escape rhythms for example, by the calcium channel blockers. The P wave is absent in the rhythm with sinus arrest. For example, genobiotics that produce vagotonia, such as cardioactive steroids and cholinergic agents, they cause absent P wave. A notched P wave suggests delay in the conduction across the arterial septum and is characteristic of quinidine poisoning. P wave decreases in amplitude as hyperkalemia becomes more severe until they become indistinguishable from the baseline. Then abnormal PR interval. PR interval, the genobiotics that decrease the interarterial or AV nodal conduction cause marked lengthening of PR segment until such conduction completely ceases. At this point, the P wave no longer relates to the QR complex. This is the AV dissociation or complete heart block. Some genobiotics suppress AV nodal conduction by blocking calcium channels in nodal cells, as does the magnesium. Although the therapeutic use of digoxin as well as early cardioactive steroid poisoning causes PR prolongation through the vagotonic effects. Direct electrophysiologic effect account for bradycardia of the poisoning. Then the abnormal QRS complex. Abnormal QRS complex, in the presence of bundle branch block, the two ventricle depolarizes sequentially rather than concurrently. Although conceptually conduction through either the left or right ventricle bundle may be affected, but most of xenobiotics preferentially affect the right bundle. This effect typically results in the left ventricular depolarizing slightly more rapidly than the right ventricle. The consequence on ECG is both a widening of the QRS complex and appearance of the right ventricular electrical forces that were previously obscured by those of left ventricle. These changes are a result of effect of xenobiotics that block fast sodium channels, like cyclic antidepressants, quinidine, type 1A and 1C antiarrhythmic agents, phenothiazines, amantadine, diphenhydramine, carbamazepine, and cocaine. An apparent increase in QRS duration and morphology, which is actually an elevation or distortion of J point called a J wave or an Osborne wave, is a common finding in patients with hypothermia. So you can see here this additional wave that has been generated because of the dissociation of the QRS complex, that is called J wave, that is seen in the hypothermia. So this is the diagnostic feature of the hypothermia. Hypermagnesemia is also associated with the widening of the QRS duration, and a slight narrowing of the QRS complex may occur with hypomagnesemia. Significant elevation in the serum concentration of potassium may also cause widening or distortion of the QRS complex. So, abnormal QRS complex is seen with hyperkalemia and hypermagnesemia. Abnormal ST segment is due to displacement of ST segment from its baseline, typically characterizes myocardial ischemia or infarction. Myocardial infarction is seen in the cocaine poisoning. The subsequent appearance of the Q wave is the diagnostic of myocardial infarction. Patients who are poisoned by the xenobiotics that cause vasoconstriction, such as cocaine, are particularly prone to develop the focal myocardial ischemia and infarction. So they present with the abnormal ST segments or ST segment elevation. However, any poisoning that results in profound hypotension or hypoxia may also result in ECG changes of ischemia and injury. In this situation, the injury may be more global, involving more than one arterial distribution. Diffuse myocardial damage may not be identifiable on the electrocardiogram because of the global symmetric electrical abnormalities. In this situation, the diagnosis is made by other non-invasive tests, such as the finding elevations in the serum marker for myocardial injuries like troponin. Here's some important facts I would like to share, that many young healthy patients have ST segment abnormalities that mimics those of myocardial infarction. The most common normal variant is termed as early repolarization or J point elevation and is identified as diffusely elevated upward concave ST segment located in the precordial leads and typically with the corresponding T wave of the large amplitude. The J point is located at the beginning of the ST segment just after the QRS complex, as we saw in this ECG graph. Also, the Brugada pattern, ECG pattern, is characterized by the terminal positivity of the QRS complex and ST segment elevation in the right precordial leads. The Brugada pattern is found in some patients with a mutation of gene that codes for sodium channel subunit. So, this abnormal ST segment or the ST segment elevation may be the gene dependent or individually young person may permanently having ST segment elevation. So we must judge ST segment elevation very cautiously. The Brugada pattern that is found with the mutation in the gene that codes for the sodium channel subunits, in these patients are at risk for sudden death. But a similar ECG pattern often occurs in patients with the sodium channel xenobiotics, including tricyclic antidepressants, cocaine, class 1A procanamide, class 1C flecainide, incanide, antiarrhythmic agents poisoning cases. So this Brugada pattern is seen in these of the poisonings. Then the sagging ST segment, inverted T waves, and normal or shortened QT intervals are characteristic effects of cardioactive steroids such as digoxin on ECG. Changes in the ST segment duration are frequently caused by abnormalities in the serum calcium concentration. Hypercalcemia causes shortening of the ST segment through the enhanced calcium influx during the plateau phase of the cardiac cycle, speeding the onset of repolarization. For practical purposes, this effect is more commonly identified by reduction of the QT interval. In patients with hypercalcemia, the morphology and the duration of the hypercalcemia, the morphology of the QRS complex, T and P wave remain essentially unchanged. Genopoietic induced hypercalcemia may result from exposure to the antacids, milk alkali syndrome, diuretics like hydrochlorothiazides, cholecalciferol, vitamin D, vitamin A, and other retinoids. So these all causes hypercalcemia. So the feature of shortened ST segment is seen in these patients. Hypocalcemia causes prolongation of the ST segment and QT interval. Further, abnormal T wave. Abnormal T wave, isolated peak T wave are usually evidence of early hyperkalemia. Hyperkalemia initially causes tall tented T waves with normal QRS, QT, and P wave. Progressive widening of the QRS complex causes it to merge with the ST segment and T wave, forming a sine wave. So a pattern of sine signature, sine is there, that is called sine wave. ECG changes of hyperkalemia may occur following chronic exposure to the potassium sparing diuretics, AC inhibitors, or the potassium supplements. So they will present with the peak T wave. Peak T waves also occur following myocardial ischemia and may also be confused with early repolarization effects. Consequently, the ability to properly identify electrolyte abnormalities by electrocardiography is very limited. Because in the electrolyte imbalance, many overlapping pictures are produced with the disease condition and even the poisoning condition. So coming exclusively to the diagnosis of the electrolyte changes based on the ECG is very limited. So we must for the electrolyte changes, we must go for the ABG. Hypokalemia typically reduces the amplitude of the T waves and ultimately causes the appearance of prominent U waves. So the reduced T wave with prominent U wave are seen in hypokalemia and the lithium. Lithium similarly affects the myocardial ion fluxes and causes reversible changes on ECG that may mimic mild hypokalemia. Abnormal, again, the narrowing of the QRS complex is seen in case of hypomagnesemia. Abnormal QT interval, that is, in that the prolonged QT interval reflects an increase in the time period from the heart is vulnerable to the initiation of ventricular arrhythmias. So QT interval is a risk factor for the ventricular arrhythmias. An early after depolarization occurs when a myocardial cell spontaneously depolarizes before its repolarization is complete. If this depolarization is of sufficient magnitude, it may capture and initiate a premature ventricular contraction, which itself may initiate ventricular tachycardia, ventricular fibrillation, or torsade de pointes. Genobiotics that cause sodium channel blockade prolong QT duration by slowing cellular depolarization during phase 0. Thus, QT duration increases because of prolongation of the QRS complex duration, and ST segment duration remains near normal. Genobiotics that cause potassium channel blockade similarly prolong the QT, but thorough prolongation of the plateau and repolarization phases. This especially belongs to ST segment duration. Hypocalcemia is caused by a number of genobiotics including fluoride, calcitonin, ethylene glycol, phosphate, mithramycin. Arsenic poisoning may cause prolongation of QTC interval and torsade de pointes. So, these genobiotics that cause sodium channel blockade and potassium channel blockade and hypocalcemia, including arsenic, they all causes QT prolongation. Abnormal U wave are typically caused by the spontaneous after depolarization of membrane potential that occurs in situations where repolarization is prolonged. Early after depolarization occurs in situations where the prolonged repolarization period allows calcium channels, which are both time and voltage dependent, to close spontaneously, reopen, because they close at a membrane potential that is above their threshold potential for the opening. In this situation, the opening of calcium channels produces a slight membrane depolarization that is identified as a U wave. Delayed after depolarization occurs when the myocyte is overloaded with the calcium, as in the setting of cardioactive steroid toxicity. So, cardioactive steroid toxicity causes abnormal U wave. The excess intracellular calcium can trigger the renoirin receptors on the myocyte sarcoplasmic reticulum to release the calcium, causing slight depolarization that is recognized as U wave. If the U wave are of sufficient magnitude to reach the threshold, the cell may depolarize and initiate a premature ventricular contraction. Transient U wave inversion can also be caused by myocardial ischemia and systemic hypertension. So these all shall be kept in mind while looking at the ECG and interpreting different types of abnormalities of the ECG waves. Then we shall look for the arrhythmias. Tachyarrhythmias are produced by the sympathomimetic agents, anticholinergic agents. Symptomatic agents such as cocaine, amphetamines causes the increase in the sympathetic tone, producing sinus tachycardia and enhancing AV nodal conduction. Sinus tachycardia may be the first manifestation of exposure to the symptomatic agents. However, other supraventricular or ventricular dysrhythmias may develop if an abnormal rhythm is generated in another part of heart. So, there are the arrhythmias could be sinus tachycardias and ventricular tachycardias. So, ventricular tachycardias are produced by the torsade de pointes, cocaine, and ephedrines. Similarly, the genobiotics that antagonize acetylcholine released from the vagus nerve onto the sinus node enhance the rate of firing, producing sinus tachycardia. The anticholinergic agents can be belladonna, alkaloids, antihistamines, and tricyclic antidepressants. Certain genobiotics are more highly associated with ventricular tachyarrhythmias following poisoning. Those that alter the myocardial repolarization and prolong the QT interval predispose to the development of after depolarization induced contractions during the relative refractory period, which initiates the ventricular tachycardia. If torsade des pointes is noted, this is undoubtedly the mechanism, and QT interval should be carefully assessed and appropriate treatment shall be initiated. Alternatively, genobiotics that increase the energetic tone on the heart, either directly or indirectly, may also cause ventricular arrhythmias. Whether a result of excessive circulating catecholamines observed with cocaine and symptomatics, myocardial sensitization secondary to halogenated hydrocarbons or thyroid hormones, or increased secondary messenger activity secondary to theophylline, the extreme inotropic and chorionotropic effects causes arrhythmias. Altered repolarization, increased intracellular calcium concentration, or myocardial ischemia can cause arrhythmias. Additionally, genobiotics that produce focal myocardial ischemia, such as cocaine or ephedrine, can lead to malignant ventricular arrhythmia. Bidirectional ventricular tachycardia is associated with the severe cardioactive steroid toxicity and results from alteration of the intraventricular conduction, junctional tachycardia with aberrant intraventricular conduction, or on the rare occasions, altering ventricular pacemakers. The only other genobiotics that commonly causes this arrhythmia is nicotine. So, in aconites, the typical arrhythmia pattern is the bidirectional ventricular tachycardia. The purpose of learning all those EC changes is important for the poisoning, as you can see that even the cardiac arrhythmias and cardiac conditions are produced by the various drugs. So, in whatever field you are, if you are practicing the medicine, medical science, then you need to know all these features, all these things that even poisons may produce the cardiac issues. So you must be careful while dealing those patients and you must care accordingly. Then bradyarrhythmia. Sinus bradyarrhythmia with an otherwise normal ECG is characteristic of genobiotics that reduce central nervous system outflow. That is the central depressants like benzodiazepines, ethanol, and clonidine. Also, calcium channel blockers, beta blockers, and cardioactive steroids are the leading causes of sinus bradycardia and conduction disturbances. The bradycardia produced by cardioactive steroids is typically accompanied by signs of digitalis effect, including PR prolongation and ST segment depressions. So with this, we have learned the different ECG changes and the cardiac arrhythmias. Now, how to manage such cases? Typically, we don't need to manage a lot of drugs for every conditions. We just need the antiarrhythmic drugs to manage those conditions. And typically, the lignocaine amiodarone are the generally first-line agents for stable monomorphic ventricular tachycardia, particularly in patients with underlying impaired cardiac function. Sotalol, that is beta blocker, is an alternative for stable monomorphic ventricular tachycardia. Unstable rhythms require cardioversions. The cardioversion is the procedure that uses quick low energy shocks to restore the regular heart rhythm that you may see when you would have training of the BLS or ACLS. You learn to use the defibrillators. Atropine may be used when severe bradycardia is present. So, the important drugs that we must know is the lignocaine. Lignocaine is given in the dose of 1 to 1.5 mg per kg IV for refractory ventricular tachycardia or fibrillation. An additional bolus of 0.5 to 0.75 mg per kg must be given over a period of 3 to 5 minutes. Total dose should not exceed 3 mg per kg or more than 200 to 300 mg during an hour period. Once the circulation has been restored, begins the maintenance infusion of 1 to 4 milligram per minute. If arrhythmia recur during infusion, repeat 0.5 milligram bolus and increase the infusion rate incrementally, maximum up to 4 milligram per minute. In the child, the dose of the lignocaine is 1 milligram per kg initial bolus, followed by continuous infusion of 20 to 50 microgram per kg per minute. Lignocaine preparation shall be done by adding 1 gram of lignocaine in 250 ml of 5% dextrose with water to make it 4 milligram per ml solution. With this, we have covered the how to manage the circulation. Then in the resuscitative measures, there comes the management of depression of CNS.